Hello everyone, my name is Arzu Bashir and I'm here today to present my DNP Quality Improvement Project. My topic is Implement Medication Review, Reconciliation via Brown Bag Method to prevent polypharmacy for age greater than 65 in the primary care setting. My chair is Dr. Rebecca Sutter, and what you're seeing on the display is my poster, and we will begin with introduction and background, and I will navigate through until we get to the conclusion. Here we go. Introduction and background. Geriatrics are on multiple medication, also known as polypharmacy, greater than 5 medication at the same time, and are facing various problems including developing adverse drug reactions, inappropriate prescriptions, and increased hospital stays and readmissions. With the increase in the global geriatric population, we anticipate tremendous strain to the healthcare resources, making effective medication review and reconciliation even more challenging. The number of older people aged above 65 will increase to 2 billion by 2050 based on existing prediction. The Center for Disease Control and Prevention stated that there are about 1.3 million patient visits to the emergency department, resulting in approximately 350,000 hospitalizations annually related to adverse drug events. In addition, polypharmacy-induced adverse drug events drive medical costs beyond $3.5 billion. Therefore, there is a need for effective intervention to address best practices to manage polypharmacy with our aging population. The increase in our geriatric is demonstrating the urgent need to institute measures to deal with emergent health challenges that the projected increase entails. The medication review and medication reconciliations are the two measures that have improved the safety of the medications and optimized geriatric care. The healthcare system needs to ensure that geriatric patients can make effective decisions on medication appropriateness and manage their care, especially at home where there's limited support. Aligning the patient and family goals and preferences through shared decision making is crucial for the best outcomes as part of the medication review process. We will now move to project goals. The short-term goal is the primary care clinic will have an improved geriatric patient medication reconciliation process that improve the accuracy of medication information and avoid medication errors such as omissions, duplications, dosing errors, or drug interaction. My overarching goal is to improve the medication reconciliation process for the geriatric patient population greater than 65 years of age in the primary care setting to prevent polypharmacy and adverse drug reaction such as falls and hospitalizations, etc. We will now move to project and aim. Project purpose and aim. So the purpose is to educate to improve medication review and reconciliation process and elderly patient appointment reminders to bring medications in brown bag for medication review. And my aim is to improve the process of medication review and reconciliation by the medical clinical staff, front desk staff, and to reduce the polypharmacy and its adverse drug reactions affecting the elderly patient over 65. We will now move to the methods. I utilize project setting Alcrim Primary Care, located in Arlington, Virginia. My project stakeholders are medical clinical staff, front desk staff, elderly patient. The project framework which I utilize for my DNP project is COMBI model as my theoretical framework, which is a behavioral model, consists of 3 components: capability, opportunity, and motivation. Know and change theory is my conceptual framework, and I utilize that also for the DNP implementation phase. Consists of 3 steps: unfreeze, change, also known as movement. Last step is refreeze. Right underneath are tools listed that I utilize. I will start with a pre and post survey questionnaire and patient data and reminder call tracking sheet, Joint Commission 5-step medication review and reconciliation process, last brown bag method. Over to the right, you'll see a QR code. Feel free to access any of these tools. And last is interventions. 3 PDS cycle, which each consists of plan, do, study, and act. The 3 PDS cycles I utilize to educate medical and clinical assistants, front desk staff about polypharmacy, medication review and reconciliation, patient appointment call, reminder to bring medications including over-the-counter to their upcoming appointment, tracking patient data such as demographic information, current medication count, identifying current potential inappropriate drug, etc. We will now move to the pre-survey results. Over to the left top, where there's orange, the table one, this one talks about the stakeholder, which is clinical assistant and front desk staff. And this right here column is question 1 through 5, and same goes for the front desk staff, 1 through 5. The questions are identical, and I use a Likert style questionnaire for the survey, and the numbers that's indicated in the table are the number of stakeholders selected that option. And I will just briefly go over first what those questions are. Question 1 is, do you have knowledge about what polypharmacy is and the adverse side effects to elderly patients, the effects on the elderly patients due to polypharmacy? Question number 2, do you have knowledge about the 5-step medication review and reconciliation process and its benefits in preventing polypharmacy? Question 3, do you ever spend extra time with elderly patients with comorbidities regarding medication review? Question number 4, are you familiar with brown bag method? Question 5, if education is provided, do you believe the medication reconciliation may reduce hospital admissions, falls, and adverse effects due to affecting the elderly patient who are taking multiple medications? So those are the 5 questions explained here off to the right. I'll go over the data analysis in a little bit, but I just want to briefly discuss about the bar graph at the bottom. You can see the pre-survey results for the total of 2 front desk staff and pre-survey results for the 2 clinical staff. The legend is indicated by the color, tells you which corresponds to the questions, and same goes on the other side. So now I'm going to analyze the data. As per the data analysis from the pre-survey questionnaire, the 2 clinical assistants somewhat agreed to question 1, question number 3, and 5. However, for question number 2, the knowledge of the 5-step medication review and reconciliation process and its benefit to the clinical staff somewhat disagreed and strongly disagreed to the question number 4 about the familiarity to the brown bag method. From the perspective of the front desk staff, 2 participated in the pre-survey questionnaire, and the results were the same as those of the clinical staff, clinical assistant. The pre-education results generalized to that half of the stakeholder participated selected disagree as their selected answer. So I will now move to the post-survey. The post-survey was collected after I had spent time presenting my PowerPoint slide on polypharmacy and medication review, reconciliation process, the 5-step, and also in addition to that is the brown bag method and benefits of it. So once the education was provided and reinforced, I then did the post-survey to see if it was impactful enough. So here you'll see the stakeholders are clinical assistant again, front desk staff. The only difference I notice here is question 1 through 8. So there are a little bit more questions on the post-survey versus the pre-survey, which I went over earlier. And again, same thing. On the table, you'll see numbers, and that just indicating the number of stakeholders selecting their answers. So, okay. Now, over to the bottom, just like before, the post-survey clinical assistant. I do want to mention there are still 2 clinical assistants still present when I conducted the post-survey. However, the front desk staff I lost one participant, so I only have the finding of the one post-survey listed on the bottom. Like again, the color on the bottom indicates strongly disagree, neither agree nor disagree. So these are color-coded to represent the bar. So let's talk about the data analysis from the post-survey questionnaire, which are shown here. But let me just quickly briefly go over the questions just so we have an idea of what they are. Question number 1 is, after the 5-step medication review and reconciliation presentation, do you have a better understanding of the roles and responsibility in the medication review and reconciliation process? Question number 2, spending a little extra time with the patient to remind them to bring all the medications in a brown bag for an accurate medication review. Is it valuable for providing high quality care to our elderly patient? Again, question number 3, do you have enough time or resources provided by the project lead and management to perform your rules and responsibility to perform a medication review? Question number 4, do you believe the brown bag method of medication review and reconciliation may reduce hospital admissions such as falls and other adverse effects due to patient taking multiple medication? Question number 5, did the brown bag method increase your confidence in helping elderly patients to complete an accurate medication review, which will be available for the providers to finalize the medication reconciliation process? Question number 6, as a result of the implementing brown bag method, do you intend to use the information learned to remind future patients regarding bringing a brown bag to their upcoming appointment? Question number 7, do you intend to spend at least 5 to 10 minutes with each patient to complete a medication review before initiating the brown bag method? Question number 8, do you think introducing the brown bag method will reduce the time allocated to completing medication review with your elderly patient? So that ends our 8 questions that were asked. And the data analysis from the post-survey questionnaire showed that the 2 clinical assistants somewhat agreed with question number 3, question number 7, and question number 8. The rest of the questions were strongly agreed, showing that the brown bag method and education about medication review and reconciliation helped the clinical assistant with the confidence to follow the process to prevent polypharmacy. Unfortunately, during the implementation process of the PDSA Cycle 2, one front desk staff decided not to participate for various reasons. Still, the project leader could successfully implement the strategies with one front desk staff, and post-survey results have proven the same. The project leader used Excel to generate the pre- and post-survey reports and attach them in the appendices section. The project leader also entered the survey filled in using paper to Qualtrics for data analysis and report generation. The project leader used Excel to do the data analysis and report, and also in contrast to the pre-survey, about 75% of front desk staff agreed in the post-survey results. So it was impactful, the presentation and the education provided. That's what that indicates. Here, I will take the time to talk about table number 3. We're going to talk about demographics, and is the number of participants. The table has sorted out by ethnicity, age, and gender, and I have them grouped here. And frequency is the number of patients, and of course I have percentages. So each ethnicity adds up to 100%. Same goes for age and gender, and the frequency, if you are to add up at the end of ethnicity, you should end up getting 27 on this, and age and gender as well. So that's how you understand it. So let's start. So I had one white patient total, and I had 2 African American, I had 22 Asian, I had 2 Hispanic, and I grouped the ages 65 to 70. I had 10 participants, 70 to 75. I had 12 participants, and 75 to 80, I had 3 participants, and greater than 80, I had 2 participants in the study. Gender, male and female, I have 5 total male gender, and 22 were my remaining female that participated. So the Asian community represented the highest number of elderly participants with 81.5%, followed by African American and Hispanic with 7.4%, and the least community is white with only 3.7% in the Alcorn Primary Care Clinic. Regarding age, the highest age group is 70 to 75%, represented by 44%, followed closely by the age group of 66 to 70%, 65 to 70 years, representing 37%. On the other hand, the lowest age group in terms of representation is greater than 18 years with 7.4%. Finally, there are more female patients than male patients. Female patients represent 81% of the 81.4%, while the male patients have 18.5% participating in the study. At the end of the cycle, the project leader and myself could analyze only 18 patients' medication data, found only 4 patients correctly follow the medication regimen, and ensure that their medications were updated in the system. These patients also were very well known about the information about polypharmacy and its adverse effect. I lost 9 participants due to several reasons. Some of the patients did not bring their medication to the office, and the other just rescheduled their appointment and didn't show up. So that's the story here. Now you see the pie chart on the bottom. This is just to help with the visualization. It's indicating that the majority of them are 82%, which are the Asian ethnicity. Talking about the ethnicity over here, and then we have the rest. So the majority is the 82, which are the Asian, and over onto the right, as you can see, the female are the majority participating, 81%, and only 19% male are participating in this study. This bar graph up to the up here, total patient number, reminded age group wise. I actually grouped them by 65 to 70, and then 70 to 75, and 75 to 80, and greater than 80. So this just tells you on the vertical the number of patients. So so that's how you want to understand this bar graph. So I had total initially 27 to begin with. For the reasons I've mentioned, I lost about 9 patients. So this is my patient that actually followed along the process. There are 18 total. So as you can see, 10, I ended up having 9. From 12, I got down to 7, and 3, I got down to 1, and 2, the greater than 8 year, I got down to 1 that ended up participating. So that's that right there. Okay, now we'll move on to the table 4, which is statistical results. So to understand this one, I tried to make it to help visualize it as much as possible. So on the current medication count, we'll call that as a group. We'll call that as a group 1, and we'll call group 2 is number of inappropriate found medication from the current medications. So the minimum medications were 6 in this study, and the maximum were 16. And then the number of inappropriate found from current medication is from 0. It ranged from 0 to 4 was the maximum. And the mean is the sum of all values, of course, all values divided by the patient. So that gave us the average. So that's our mean there. and that was 10.8, and then I got 1.5 for the number of inappropriate found from current medication. So, I'll explain a little bit on here about standard deviation measures. Standard deviation measures how dispersed the data is in relationship to the mean. A low standard deviation means data are clustered around the mean. A high standard deviation indicates data are more spread out. A standard deviation of a 0 indicates the data points are close to the mean. And now I'm going to explain about the variances. Determines that the spread between the numbers. So again, variance determines the spread between the numbers in a data set and how far each number is from the mean and every other number in the set. From the data analysis, the mean for group 1, like I had mentioned earlier, the mean is 10.8889 and standard deviation is 2.447. The mean for group 2, inappropriate medication found, the mean is 1.5, standard deviation is 1.0138. Since the standard deviation count for both data sets is lower than the mean, it indicates that the data are clustered around the mean. I used descriptive analysis because it helps to synthesize and describe data. So it's also utilized the regression analysis, and as you can see, there's a scatter plot off to the right. The scatter plot shows that the correlation between the medication count and inappropriate medications. Higher the medication count, the more the inappropriate medications were found. So there's a strong correlation between the two variable, independent and dependent variable. And I now want to go over, that's what that is indicating actually. The R squared is 0.7628. That is pretty strong correlation as compared to something like 0.3. So this is pretty high in the end, so it's pretty highly correlated. The more medications they are on, the likely they will have higher inappropriate medication in their list pile. On the bottom, I generated this bar just for visualization. That just tells you the number of participants, if you were to count them. And then the blue is the medication. They were taking the number of medication, and then the orangish color is the number of inappropriate medication, just to help with visualization. And just to point out that one of the patients was 16, and they had 4 inappropriate medications that were found. Okay, that's the end over here. We will now move to the findings. During the medication review and reconciliation process, I found that some patients were on medication requiring to take on an empty stomach like Synthroid or Aldronate. However, during the review session, the patient was not following the provider's direction correctly. So as a project lead, I intervened and educated on the proper steps to take the medication on an empty stomach so that the body can metabolize the medication properly for better efficacy. In addition, also noticed several patients were on gabapentin of a different strength, which finding out reconciled to one strength at the end of the visit. Some other findings as through the project leader and myself also found that 3 of the 18 patients were diagnosed with gastroesophageal reflux disease, GERD, and are taking medications for a long time to treat it. During the medication reconciliation review, the project leader and myself found that these patients were prescribed PPIs. However, based on the evidence-based finding, I explained to the patient that the long-term PPI has adverse effects, such as increased fracture risk and calcium malabsorption, and may affect nutrient absorption. And lastly, but not least, the project leader found many older Asian adults' living conditions are such a way that they cannot take any precautions to prevent falls. It is imperative, especially if the patient is elderly and frail, they may have the risk of falling, which is a significant side effect of polypharmacy due to taking multiple medication. As clinicians, we must keep educating them about falls, having proper lighting around the house, avoiding clutter, and ensuring they have a bar to hold onto in the bathroom to prevent fall. So now move on to the barriers. Many barriers are associated with implementing effective medication review, reconciliation programs in the primary care setting. Among those many barriers are the lack of patient participating in the quality improvement project was one of the project's lead barriers, unfortunately. For example, even though this quality improvement project was relatively a straightforward study and process, the project lead myself was not successful in obtaining 25 patients than anticipated due to limited time, lack of interest of the patient to participate by their own choice. In addition, during the PDSA cycles working with elderly patients, I found that some patients showed more interest in learning and understanding the adverse effect of polypharmacy, and some were not due to their cognitive decline. Another critical barrier the project leader noticed was the patient's spoken language, especially when not accompanied by someone who speaks English or Spanish. Unfortunately, most of the patients in this primary care clinic and patients participating in the implementation were just middle school graduates from their home country who needed more help with English knowledge. So health literacy limited. So recommendation, the plan to study act cycle must be completed frequently. That's the recommendation by staff and adapted to the clinic's need to maintain sustainability. For example, the project leader suggested to the management that educating new staff about medication reconciliation and medication errors as soon as they start at the clinic is crucial to ensure the process is followed. Plus, the PDSA cycle should concentrate on implementing and extending it to more elderly and new patients to prevent polypharmacy in the clinical setting. In conclusion, polypharmacy is a concerning issue among the elderly population that needs a solution. Many elderly adults are left without consistent or reliable caretakers and rely on healthcare providers. So, healthcare providers should advocate for the geriatric population and implement processes and tools such as medication review reconciliation using brown bag method to recognize and prevent polypharmacy. The results of this project are limited based on a small sample size during the implementation. However, the pre and post survey request results indicated the process was easy to use for sustained integration into the medication review reconciliation process using the brown bag method. And I now want to take this special time to thank, to acknowledge very important mentors. I want to take this opportunity to thank every one of my professors, my chair, Dr. Rebecca Sutter, and Dr. Masara Tahira, and all CRIM staff for allowing me to implement this quality improvement project successfully. This now takes us back to my poster, and as you can see on the bottom, e-portfolio and references, feel free to use the QR code to access my portfolio, and as well as my references are listed there on the second QR code. That ends my DNP scholarly work presentation for today. Thank you so very much.